fibers delaminate, because this is not a ball and socket joint. It actually falls into the category of an adaptable fabric. So then when we squeeze the spine and bend it forward, it creates hydraulic stress in the gel, which proves posteriorly, if you could see that. Now we're going to stack the spine, and notice that when you squeeze, nothing hydraulically comes out of the posterior fissure. So you see, posture matters for this particular subcategory of back pain. And if you're upright and stacked, you can load your spine with a very large amount of compression. So it's an injury and a pain pattern completely dependent on posture and hydraulics. So when we look on the left-hand side in terms of differential diagnosis, when you're younger, the pain patterns are dominated by the disc, sacroiliac joints, muscles, and those kinds of things. But as you get older, you're much more likely to have several elements that are more involved in pain. That the set joints are much more likely to be involved in pain. The ligaments thicken up with arthritis, create smaller holes for the nerves to travel through. Some people will have compression fractures from osteoporosis and mineral loss. And hip pain is quite often a correlate of the back pain when we get older as well. So we're doing pattern recognition now as we age. So now let's look at the categories, subcategories. There's just a few samples of them that cause pain as we get a bit older. So if I was to, and if you can see me now, if I bend my knee, there you go, if I bend my knee and bend my head forward, I cause my neural tract, my spinal cord, to migrate towards my head. And when I flex my hip and my knee and I look up, I migrate it the other way. So there might be a clinical test, because what we're doing is this. We're migrating the cord and nerves up and down, and we will get a floss of about 2 centimeters. That will cause radiating symptoms in the person who has this condition. Much more common as we age. So this particular model, the brass rod simulates the spinal cord, but now I'm going to show the effect of posture. So you see the arthritis that's developed around the edge of the labrum of the vertebra, and that arthritis will grow into the holes where the nerves traverse. So I'm just going to play with subtle posture of that joint, and you'll see where the brass rod falls out, showing how we teach people the posture to allow the nerves to flow as they get older. I'm just going to flex a tiny bit, and you'll see the brass rod falls out very cleanly. It's a nice little teaching tool. Now, what have we done here? Okay, so when you are younger, the typical pattern is sitting at the computer causes pain, and the therapy was to go for a walk. But as you get a little bit older, the polar opposite pattern happens. Walking now increases your symptoms, and sitting down takes them away. So this isn't degeneration. It's simply changes that occur. Well, let's skip ahead now to chapter 5, because I said you probably will not get a thorough assessment from your clinician, and I'm afraid you're going to have to do one on your own. So that's what chapter 5 guides you through. So here is a test that you might want to do, and if you can see me, I'm just simply sitting on a stool, and I'm going to grab the seat pan of the stool and pull up, and I'm going to pull up about 20 kilos, but before I do, I'm going to sit tall. I pull up and compress my spine. Let's assume there's no symptoms. But then I'm going to slouch like this. And let's assume that does cause symptoms. You've just proven right away that the curvature and the posture of the spine is causing the pain. Then we might play with neck posture, which I've already shown you, changes nerve tensions, and we will figure it out as to the exact nerve, the exact level of your spine. There might be more than one level, etc. Well, the great Carol Levitt, who became a clinical mentor for me, the great Czechoslovakian urologist, used to say the first task of the clinician is to show the patient the cause of their pain. Well, most of you will have experienced clinicians who've never done that for you before, because that is the foundation for removing the cause. So let's do that now. Consider back a few slides ago where I showed you micro movements to a damaged joint is triggering pain. How do you arrest the micro movements? One of the first things we might try is called the abdominal brace. To coach that, we ask the client or patient to poke their fingers lateral to the navel into the abdominal wall and now push out. So it's not sucking in, and it's not hard bracing and holding of the breath. It is simply pushing the fingers out, and that is tuned to the level appropriate to take the pain away, because there's a cost for doing that. It's extra load on the spine, obviously. Then for the person who had pain caused by putting the spine in different postures, we would teach them the shortstop squat. So play baseball, we've all done that. I'll just move the camera down a little bit. Slide your hands down your thighs and move your pelvis back. Grab your knees with your hands shaped like a V. Now, change the shape of your back. There's humping up like a camel. There's lifting my tail to create a hollow. You will find a sweet spot that creates great resilience. Now, lean forward. Do you see how I'm a leaning tower over the ankles? Push your toes down, lean forward, and don't shrug, but anti-shrug. Now I just stiffened my spine into the sweet spot posture that you just determined. And the final bit is the cognitive muscle memory development of do not lift with your back. Instead, stiffen your back into that sweet spot posture and pull your hips through. And the final bit is to transfer that to real life. Let's pick up your grandchild. Go down, play shortstop, grab your grandchild, slide them up your thighs as you pull your hips through. Most of you, for the first time, will not experience the pain if it was triggered by a deviated spine posture, because you just addressed that very specific cause. Well, now let's talk about spine hygiene. Spine hygiene are tools that we teach to change habitual movement patterns that continually pick the scab, and it creates pain-free movement capacity. So instead of you getting so much pain by lunchtime that you're quite disabled for the rest of the day, you've now extended that by creating training capacity. So let's assume the person walks into your clinic on the left there and unties their shoe in the posture that you see. And then you do the orthopedic test just to prove that what they just did untying their shoe was exactly their pain trigger. Well, now it's a matter of coaching a strategy to still tie and untie the shoe, but do it in a very spine-friendly way that did not trigger their specific pain. Instead of sitting on the bench, put your foot up on the bench. Now the trick is to take the pelvis to the target. Bend the stance knee, allow the knee to drift over the foot, and you see how I'm scissoring down and I can tie my shoe, not going anywhere close to the quantified pain trigger. So you've addressed the cause. Slowly, the pain will wind down. Then we teach work technique. You're all familiar with the bow and arrow, where you pull on the bowstring, push away the bow. That's creating what we call the archer's bow. there's no load on the low back. So you see, parlaying that physics to the worker on the right side, pushing down on the support and pulling up on the block allows you to lift with very little stress for the low back. Well, now it's time to take this mechanical linkage that we all live in, our body skeleton, and tune it for pain-free movement. Well, there are certain physical laws that govern a linkage. And the first law is proximal stiffness allows distal athleticism. I'm going to wiggle my finger very quickly back and forth. In order to do that, I had to stiffen my wrist. In order to wiggle my wrist, I had to stiffen my elbow. If I want to push you with my bench press muscle, distal to the joint, that muscle creates arm flexion and the desired push. But proximal to that joint, it just bends my rib cage. So that's what we call an energy leak. So I say I could bench press 400 pounds or 200 kilo. It's absolutely useless without core stability. So I needed proximal stiffness to arrest the proximal movements. So all of the effect is generated and expressed distally. You can't even walk if you don't have appropriate core stability. It would never allow leg swing because your pelvis would just bend off to one side, allowing the spine to collapse. So how do you build the mother of all stability, the absolute essential determinant in the core? We spent years trying to evaluate and search and measure for the very best exercise. We ended up calling them the big three. You have to build a guy wire system around the spine with the front, the sides, and the back, and they've become quite well known around the world, known as the big three, and Waterloo has received a lot of credit for this. The modified curl up on the left, there's a lot of precision there. One knee is bent, which takes the tension out of the neural system. Hands under the low back, where the person curves the low back into a sweet spot posture. And then the head, shoulders, and neck are hovered just 2 centimeters. That's all. Some people will get neck pain, not realizing that if they touch their teeth together, drive the tongue hard to the roof of the mouth, and then grimace down just a little bit, you see the neck deep flexors I've just activated to stabilize my neck. And in some people, that will take their neck pain out. So again, you keep working on the assessment and applying the appropriate coaching cue to systematically address and eliminate their pain triggers. For the sides, there's no better exercise than the side bridge. It's a 3-point bend from a mechanical sense. There's zero shear load on the spine, and we will choose an appropriate style there to match the person. But say you've had knee replacement and you can't get on the floor, then we would modify it for a standing side plank that you see there. Now for the back muscles, what we call the quadruped or bird dog. You can see we extend one arm or one knee. You might go to the physical therapist and lay on your tummy and do the Superman exercise, which is 4 times the load to a hyperextended back, which will cause pain more than it will take pain away in many older people. Again, we keep modifying the exercises, working with what the patient gives us. So a standing bird dog might be an appropriate modification for some. Well, let's skip ahead now to chapter 10. To have a well-functioning back, you have to walk. There's no option. Frontal plane strength is absolutely critical for spine health. Every time I take a step, if I don't have frontal plane strength, my pelvis bends and I collapse to the floor. There's a muscle called quadratus lumborum that runs either side of the spine. Go to the neurology ward and find a child who's had a paralyzed quadratus lumborum on one side. What's the first thing they can't do? They can't even walk. That's how important core fitness and functioning is. But walking, as we get older, to keep it pain-free, requires an upright posture. So if you are walking like the model on the left, they are under chronic contracture. The person on the right has learned to hover their ears over their shoulders, over their hips, and swing the arms about the shoulders. So instead of becoming a strength athlete with concentric contraction and eccentric contraction, they become an elastic machine where they store and recover elastic energy very efficiently. They are naturally flossing the nerve roots. So as you will see, the key is to walk after every meal as we get older to preserve that pain-free ability. But some people struggle, and we have to get them out of the hole in order to tune their body to accept pain-free walking. Sometimes it's appropriate to lay on the tummy for 2 or 3 minutes. Sometimes putting a chin under a fist under the chin. Sometimes walking up the wall or walking up a tree. Or the one on the right we call a park bench decompression. I'm just going to show you what I mean. Say you get pain in your back after walking for 5 minutes. Go for a walk in the park and walk for 4 minutes, so you've guaranteed absolute success of walking for 4 minutes. Now you restore. I'm going to take my earbuds out and I'll just demonstrate this. So I will walk over to the back of a park bench, or perhaps the back of a pickup truck. I'll put my heels on the back of the bench, the heels of my hands. I will go up on my toes, up over the bench, and take the weight down my arms and just hang. Now, for about half of the people where walking causes their difficulty, that will allow them to walk another 5 minutes pain-free. Well, if you did that cycle 4 times, for the first time in several years, that person has now just walked 20 minutes, guaranteed successful cumulative walking. And that might be an example of how, for that individual, we would get them walking again. Well, here's a real patient now. You'll see on the left, he's come to the clinic. His back muscles are rock hard. He has a chin-poking demeanor. In order for gravity to support his head, his back muscles are rock hard. Everything he does causes back pain. We did a little maneuver, which I will reveal in a minute, that took 4 minutes, and it changed his anatomy so he could, and I'm talking about the compliance of the joints now, so he could now stack his ears over his shoulders and for the first time shut down the back pain mechanism. But here's the thing. We can change the mechanics and anatomy through adaptation, but it's the neural system, the muscle memory, and the habit that then takes over. Do you know, in 10 minutes, he was right back to his old posture. And I said, we just gave you the hardware to take your back pain away, but your habit was to go back to your forward chin. So we repeated, and I then gave his wife full license to nag him so that he could create a new default muscle memory and take his pain away. So the mechanical intervention was a thoracic spine extension that you see I'm facilitating on the left, but you can then coach the person to do it themselves on a chair where they kneel and they apply about 2 kilos of force, extra force, down through their elbows into the chair, and then hold it for 10 seconds and release and pull their buttocks back towards their heels, which operates the stress right here to allow thoracic spine extension and therefore addressing their specific pain mechanism. Peggy, I think I have about 4 minutes.
Okay.
Can I finish off this last point?
Absolutely.
Because it's a tremendous University of Waterloo story.
Absolutely. Please do.
If you are a frontline clinician, you will have had couples coming to you and saying, we are now abstinent because the last time we had sex, we knackered our backs so badly that we haven't had sex for half a year. Do you know there's no guidelines that exist anywhere to guide clinicians on what to say? So we kept hearing this over and over again, and there was no one in the world who would take this on. I went to the ethics committee with the graduate student, Natalie Sidorkowitz, this became her thesis. And we fiddled around for a couple of years trying to get it right. And then finally, because you can imagine, there's no university in the US that would go near this with a 10-foot pole. The public would be crying for their public to be, their funding to be rescinded, probably excommunicated from the university. After that period of time, Barbara Shoemaker came on, director of medical services at the university, and Barbara said, this is a real problem. We can show leadership and provide to the world a solution. And then President Ferdinand, in his first year of his presidency, then came also and said, this is a real problem, and the University of Waterloo is going to support this. So Bertrand Russell said, why not? And so did the university, as it did so many times throughout my career. So a little bit of a funny anecdote, graduate students would hear about this and come up to me and say, if we volunteer for your study, do we get to choose our partners? And of course, the university had to handle this right. There was no one in the extended university community that participated in this. All the couples were in very long-term stable relationships and that kind of thing. But nonetheless, we did the study. We ended up with 13 couples where we gave them different styles. We measured the loads in their back and their hips to find out what were positions that were safe. It didn't cause back pain. It's just they had no idea. Now, the end of the University of Waterloo story is this. This was the most successful media launch in the history of the university. This study directly touched over 2 billion people on this planet. If you take the readership of the newspapers where this was written up, it was over 2 billion people around the planet. We were front page in China, Costa Rica, Italy, Spain, Norway. We even made the front page of The Economist, which is a fairly conservative newspaper or magazine, and you can see the headlines there, broke back mounting, sex and backache, and they wrote up a story on this. But our object, recall now, was to give the clinicians an atlas where they could then assess the pain triggers very specifically for the person who was suffering. And we then subcategorized them and gave them this atlas to guide and coach pain-free positions. So talking about changing people's lives, that was always the mantra of our lab and our students. Change people's lives. The final bit, and there's a chapter in the book on this, is surgery for you. As you get older, surgery, in terms of its ability to remove back pain, becomes less and less and less. And the reason is, when you're younger, there's usually a single target. And if the surgeon gets it right, that knife will cut the pain out. But as you get older, there's more and more targets. So the risk that you, or the chance that you are able to cut the pain out greatly diminishes as you get older. But curiously, surgery, as we probed it, works for a lot of people, not because they're cutting the pain out. It's because they create forced rest. So you can imagine the person who says, you know, I have to go to Good Life Fitness every day and ride the elliptical for 30 minutes. Otherwise, I'm going to murder my husband or my kids or my wife or whatever it is, because it's my stress reliever. They are addicts to exercise, and they will never get their back desensitized from the pain. But surgery forces their rest. So we created this little game, and we called it virtual surgery. So I would be very dramatic. I would touch them on the shoulder and say, there, now you've had surgery. Tomorrow you're going to behave like a post-surgical patient. You're going to rest. You'll get up and go to the toilet, have a short walk, and we're slowly going to build you back with proximal stability and the motor control through your body to create it in a very spine hygienic, stress-free way. We're going to create patterns where you can push and pull and lift and lower and carry. And build you up progressively. And it is that was making the difference. So of course, there are times for surgery, no question. But here was the clinical proof. We followed up with every single patient we ever saw in the history of the clinic at the university. Of the patients who were told, you've tried physio, chiro, you've been to the shrink, you've seen the surgeon, you've tried everything. The last thing you have is to try surgery. If you fell into that category and you did the virtual surgery program that I just described, 95% of them were able to avoid surgery, and in a 2-year follow-up, we're glad that they did. Let me summarize now. A lot of what we did involved pattern recognition. We would look at older people who led a physically successful life. They'd retired and they still had a lot of pain-free ability and physicality. And there were some patterns there that emerged. I'll give them to you. Rise in the morning at the same time and do your chores. Do not get on your computer. When I was department chair, I would take the younger professors and I would say, don't you dare go near email. Don't you even open that computer till after lunch, because they found their productivity increased, their health increased, their back pain decreased, etc. Every time you eat, go for a walk, just a short walk. And now I'll just introduce to you what I call the biblical work week. When I started with Bob Norman in 1982, we never had a computer in the laboratory. We did everything manually, walked around, we talked to one another. But look what our careers became. I retired officially, I guess, was that 4 years ago now. And everything was online. I was losing my health and in pain because of the time I spent at the computer. I don't have any pain now. I feel fabulous. This is my week. I do physical labor every day, but I do try to plan my week so that 2 days a week I do some strength training. One of the most important things as we get older is don't fall. Well, what's one of the prophylaxis for falling? Maintain hip power. Maintain the ability to quickly get the leg out in front of you to arrest a fall. That is hip power at strength. 2 days a week. 2 days a week, I work on mobility. I didn't need mobility when I was younger, but I do now for my neck, my shoulders, and my hips. Appropriate mobilization exercises. That isn't just stretching, not at all. It's a very scientific program that addresses fascia, nerves, muscle, joint capsules, etc. And then 2 days a week, I do something for the ticker. I'll make sure I go for a bike or a swim or a cross-country ski or whatever the case may be. And the 7th day is the real wisdom, rest. That 1 day of physical rest is for adaptation. The reason we exercise is to allow the adaptation stimulated by the exercise. And too many people fail to allow that recovery and adaptation. So with that, there's some resources there. And I had this cartoon made, so I have to show it off. But with that, I know you all have different pain triggers. And I hope there was a little bit of something there that made it worthwhile to spend your half hour with us today. So thank you very much, Bob and Peggy and Lynn and Jim Frank. And thank you for an absolutely fabulous career at the University of Waterloo. And that's about all I have to say.
Thank you very much, Stuart. That was really informative. We do have a few questions that were sent to us in advance, and I wonder if that we can start off with those. I think you were sent those questions earlier today. I don't know if you've had a chance to consider them, but
well, I live in Muskoka now, and if we had a windstorm and a power failure in Waterloo, okay, you let the hydro guys take care of you, and the power came back. But where I live now, it means you can hear off in the distance chainsaws and generators as all the neighbors get together to clean each other's trees out. And we haven't had power for 2 days out at our cabin. So I went out there at 1 o'clock this morning to take out a generator and get some heat going on for the neighbors so that their pipes didn't freeze. But anyway, I came back this morning. So I haven't, unfortunately, been able to catch up on email.
They're fairly brief and fairly pointed questions. So let's just take them one at a time, and then we'll open it up to our attendees. So the first one, it's from Ron Champion. He's a member of our board. He says, if I'm perusing items in a shop, my lower back aches after less than an hour, but I can be on my feet for 4 hours or lifting heavy items without pain. Why?
Well, the answer, unfortunately, is if I could do an assessment, we would find out with precision why. But here's a couple of suspicions that I would have. So I'm going to stand up and just move my screen like that. And I'm just going to hold my mic like this. Ron, if you're there, stand up and work with me. Take your finger and your thumb and place them either side of your spine and your low back and feel the turgor of those muscles. And as you arch back and get your head over your shoulders, over your hips, you will notice that the muscles go soft, they go silent. Then I want you to bend forward slightly and you'll find the muscles contract hard. Now poke your chin, the muscles are on. Pull your chin back, the muscles are off. Round your shoulders, the muscles are on. Come back. So this is static loading. If you are working in the shop in a static position, if you go to the shopping mall and do mall strolling, feel if you have that chronic contracture. And if it turns out that that is your pain trigger, we've just found the cause. So when you stand up, walk around, the muscles contract and relax, and they don't build up that cumulative load or fatigue or whatever your particular trigger is, because load to tissues is a magnitude, it's a duration, it's a frequency, but it's all mitigated by frequent rests. And they can even be micro rests, just allow the blood to perfuse for a second or two. So I don't know the answer without assessing you, but there's a little bit of a start to the conversation. So sitting for a long period of time, standing where chronic low-grade contracture fulfills the duration component of a cumulative load.
Okay. So we'll go on to the next question. This is from Susanna, and it's, do you have a listing of physiotherapists in Kitchener-Waterloo that follow your method and will look at the whole body and not just the low back? Does the kinesiology department at the university take appointments for assessment of back issues?
I just see this note from Carolyn. Carolyn, you're still correcting me. Go on full screen. Let me just stop sharing the screen. Oh, am I on full screen now?
No.
Okay, so.
Yes, you are.
Oh, I am.
You are on full screen. Oh, no, not your screen. Just take that off.
Stop.
There you go.
Okay, thank you, Carolyn.
You're welcome. I've just taught a whole class online this summer, so I've learned to play with these things.
Okay.
Fabulous. Well, there's several layers to the question that you just asked. So first of all, we have a list of clinicians. They're not all physical therapists, though. We don't care whether they're MDs, chiropractors, kinesiologists, or whatever. We want them to take our courses and then pass quite a fairly rigorous exam and prove to us that they know and are have the numbers to prove that they're successful with back pain patients. So I audit them. We have a list on backfitpro.com. So there's two portals of entry. If you're a clinician entering, you will see that. But if you're a patient, click on the patient side, and then it will say a list of McGill Method certified practitioners, and then McGill Method master clinicians. Those are for the real heavy, difficult cases. Now, do they look at other areas of the body? And the answer is no. I know my wheelhouse, and it's the low back, and I really don't go outside of that. So that's the requirement of our clinicians. However, I can tell you as a master clinician, Dr. Ed Cambridge in Mississauga is an absolute master with cervical spine conditions as well, whereas I'm not. So anyway, you can start with our website and see the list of clinicians who've made the grade, so to speak. And I am very confident in their ability to address with specificity a person's back pain.
And that's backfitpro.com.
Yes.
Okay, thank you. And then the last question that was sent in advance from Rich. I think you once wrote that gym users often choose the wrong workout equipment, most notably the treadmill. What would you recommend for a fairly healthy 73-year-old?
If I could meet Rich, I would then be able to answer that question with precision, because I would like to know a little bit about his past injury history. I would like to know about his current level of fitness. I would like to know what his fitness goals are. And I might say that there's too many people training like Navy SEALs. They're trying to get their personal best and all this sort of thing, not realizing that actually shortens the athleticism in their lifetime. If they had the goal, my goal is I'm going to be the best rocking grandfather or great-grandfather when I'm 85. Now, if we can agree that that is the real goal, chances are we won't use many machines in the gym. We will do we're going to follow the biblical work week. Now, I need to know what things are stuck and will allow longer duration athleticism if we can unstick them. So that would be the specificity of the mobility part. For the strength, I want to know, does he really want to chop his firewood for the winter with robustness and competency? Then I would consider a hip hinge pattern. We might load that. We might do a push exercise, which is simply push-ups. So much better than a bench press on a machine in terms of challenging and balancing the whole body. A pull exercise might be pulling on TRX straps, which really doesn't involve a machine at all. Picking up and carrying a suitcase, that's a unilateral suitcase carry. We happen to use kettlebells around here. But again, it all depends. So I'm not trying to avoid the question, not at all. But to tune this mechanical linkage, consider your car. Would you go to a car mechanic and say, my car isn't working, and the mechanic says, good, we'll replace the engine? It doesn't work that way. They do an assessment and figure out exactly what the car needs, and then they tune it. And the body is a machine in the same way.
Okay, great answer. I'm glad that we're recording this, because hopefully if that person is not attending today, they could pick up this answer on the recording. So those are the three questions we had in advance, and we determined, I think, earlier that we would use the chat at the bottom of your screen if you'd like to type out your question.
I don't have any questions at the moment.
Or if you're not, that's not working, I can review the screen. If anyone wants to hold up their hand, I can check that as well. No. Okay. Well, I think then, thank you very much, Stuart. I don't know what is, there are any other comment from attendees today that they'd like to make.
Well, I'll just say thank you once again to the organizers and all the rest of you in the audience, and to Bob. I hope that time you took 30, how many years ago was that now? I'm not very good at arithmetic. 38 years ago, where you sat me down and we had to review those horrific films of me doing my first lectures and you critiquing together. I hope all that paid off.
Chandrika had a question.
Indrika?
Unmute yourself there.
Yeah, no, I don't have a question, but I just want to say this is a very important topic and very informative. Certainly, we have learned a lot. Thank you, Dr. Stewart. Thank you.
Yeah, well, I appreciate that very much. Thank you.
And I'd just like to say thanks, Stu, and congratulations on your Order of Canada.
Oh, thanks, Carolyn. And yeah, we got to know each other quite well over the years, and I value that.
Thanks to my back.
Well, may I reveal that we're a couple of old hippies together. We both had hip replacements, so.
Oh, but I've had two.
Well, you're always special.
Take care.
Bye.
Bye.
Thank you again, everybody, for joining us today.
And please send your comments to uwra@waterloo.ca rather. We would like to get feedback, any ideas for future topics, speakers. We would like to do this again, and we'll gain experience as we do more of these. And we're really looking forward to seeing you all soon. Well, I shouldn't say soon, but once we have this virus under control, I'm hoping in the next year we can get back together for a visit at the university.
Thank you.
Take care, everyone.
Thank you, Stu.
Thanks, Jim.
Thank you again.
It was great to see everybody.
Great to see you too.